Well, welcome, and we're talking once again to Professor Robert Clancy. I'm not going to run through all of your qualifications on this, Robert, but you've been a professor of pathology and you're still working as a consultant physician, and you've got a list of research publications that's considerably longer than my arm. So, and you're basically an immunologist. This is what you do. So,
that's right.
Thank you for coming back. So the immune response has been in the news a lot lately, clearly. And the immune response is something that the body does in response to infection. Now, I want to kind of do this talk for the interested lay viewer. We use this term infection a lot, but what does it actually mean, an infection?
Well, John, as you indicated, we decided to do this talk, or maybe a series of talks, related to working towards a better understanding of what's going on in a particular infection, which, of course, is the pandemic of COVID-19. An infection is an invasion of the body spaces by a microorganism, which could be a virus, it could be a bacteria, a fungus, a protozoan, parasites, a whole range of viable organisms. And that infection, if not met by resistance, mediated by the immune system, will lead to sepsis and even death. And so the way the body handles that infection becomes critically important. The way in which the body handles the infection has become highly complicated as a result of 100 years of study where initially it was nice and simple, then the simplicity became confused by everyone looking for a molecule, millions of molecules, in a highly complicated, regulated system with amplification mechanisms, damping mechanisms, and what began as a black box with the infection entering into the black box, and out of the black box came a response which would neutralise that infection. And that's what immunology was supposed to be all about.
This has always fascinated me, Robert, that we live in this milieu of viruses, bacteria, as you say, protozoa, the larger sort of eukaryotic organisms, and untold numbers of viruses and bacteria, and yet just under the skin, in the lower layers of my epidermis, it's sterile. There's like no microorganisms there. I mean, it's just. I just find this amazing. I mean, what sort of innate mechanisms are there that keep us sterile? Just those few millimeters under the surface of the skin.
Well, I think that's a really astute observation, John. Two things need, I think, to be said. The first is that you're absolutely right. The body, for all intents and purposes, is sterile and needs to stay that way. The finely balanced mechanisms of metabolism, the way in which the organs and cells talk to each other, the tissues behave, requires no bacteria, no viruses. It's not quite true because we can integrate some of these into our genetic apparatus, but by and large, as we understand infection, it needs to be sterile. And so the body has developed a highly efficient system for ensuring that occurs. Now, the second point you made, which is important, is that there are millions and millions of different patterns of organisms, and the body had to generate a mechanism of being able to cope with every one of these systems. And yet at the same time, it's got to be able to get rid of every one of those efficiently, effectively, and fast. And the way it does this is have a genetic apparatus which throws up the bits of genes. We call it the lotto system. I'm not sure what you call it in Britain, where you buy a card with numbers and they throw these little balls up which have numbers, and 5 of them will line up at the end. Well, that's exactly what sort of happens with the genes. And so you have this lotto mechanism going, and they fall out so that by some amazing chance, you've got all the possible patterns, something like 10 to 20, 30,000 of these patterns that can exist in nature. So by virtue of the number that you have, you cannot have a great number of specific receptors to meet each one of these different patterns. And that's why the body has developed a two-level immune mechanism. The first is the specific immune mechanism, which has a receptor specific for every one. Well, each cell which has a receptor has a specificity for only one of those 10 to 20,000 different patterns. But the way it copes with a rapidly dividing bacteria or virus is to activate, like a general activating foot soldiers, a number of mechanisms which are totally non-specific and can be used by any and every one of these particular patterns. And that system is called the innate immune system. So you have the adaptive, specific immune system, and then that triggers the foot soldiers. And the same foot soldiers are triggered by every one of these different patterns. And those innate mechanisms employ amplification mechanisms based on secretion of a hormone that will act on many other cells, by enzymic systems which create more and more enzymes and build in this massive amplification. And it's a bit like having a hand grenade where the trigger is this innate system. You pull a trigger for that and then it blows up to kill the virus or the bacteria. But this is the rub, that if you don't have this highly coordinated, that hand grenade will kill everything around it. It will kill your own tissues. And so a highly tuned, efficient immune system is going to activate just enough of these innate systems to get rid of the target bacteria or virus. If it doesn't do that, then you blow a hole in normal tissue. And that's what we call hypersensitivity. And that's the basis of a great number of different diseases. It's the basis of why, if you do not contain a COVID virus in the airways, if it gets out into the gas exchange apparatus of the lung, which is where the systemic immune system operates, then that can blow up like a hand grenade and cause viral pneumonia and activate a whole range of these pathways of immunology, which we can call in its extreme form a cytokine storm. Does that make sense?
It does. It's just incredible. So we've got these potentially billions of different types of invading organisms, but we can classify these into groups, of 10 to 20,000 for the initial recognition system. And then, because we've only got about 22,000 genes in our whole bodies, functioning genes in our whole bodies, we can't have a gene for every one. So we have these components of the genetic material, the DNA, and they kind of rejiggle to recognise,
recombinate,
to make an antibody.
Exactly.
Yeah, to make an antibody that responds to the specific antigen that's invading us. It's just, it's impressive.
Yes. So these lotto balls, the little coloured balls, they all come from different genes, but they can rearrange themselves.
Yeah,
a bit like some of the flu viruses can.
Yeah. So yeah, just in the same way as the viruses can recombine, we've got this set of genetic instructions that can recombine, and they'll put together these small strings of amino acids that will generate these immensely complicated but phenomenally powerful immune proteins.
Yeah, absolutely. Yeah. And each of these immune proteins or antibodies will have that specificity for that particular virus or particular antigen on that virus, because each virus will have maybe 20, 30, 40 different antigens.
Yeah. This is great, because these are things I've taught for a long time. It's very reassuring to hear that they're vaguely correct, because it is so complicated. To have a conversation with someone who actually understands this is really quite reassuring.
Well,
if someone's,
I can't hide behind complexity, because it's basically the concepts are simple. We immunologists have made it extremely difficult to shut everybody else out sometimes, I think, because we use mice We're very good on the genetics of mice. We're very good on terminology for cytokines and monoclonal antibodies. And if you strip all that terminology away, the simplicity was really there in around 1900 when the original Pasteur and Koch and the other German scientists put together a very basic immune system. And we've made it more complicated as we've discovered more and more layers of complexity. But still, the system they put together included pretty much everything we've talked about today.
This is one of the reasons I really wanted to have this conversation, because I've tried to read some original papers on immunology, and as you say, they're often related to animal models. That they're very complicated, but you're actually a practicing physician, so you can relate this to the real world. I mean, what generic features do people exhibit when they have systemic infections, whether it's bacterial or viral?
Well, the symptoms that people get from infections are much less diverse than the numbers of viruses and bacteria that could cause it, because by and large they reflect a toxicity, an intrinsic toxicity that many microbes have. For example, I think everyone was a little surprised when COVID came and COVID vaccines came, and we found the spike protein was incredibly toxic. So that created problems of its own, and as we know. But the general response to that virus, any other bacteria, is mediated largely by the molecules that are made by the specific adaptive immune system and the innate system. And these are called cytokines. It's really a language. They're words of a language. This is the way the cells communicate, that the adaptive immune system tells the innate system to do something. It doesn't shout it out and use headphones. It actually says, here is this molecule I'm going. That molecule will bind to a little receptor, and that will trigger a response. And some of those responses, that whole response, the whole response by the body is called inflammation. And inflammation is a normal physiological event. The purpose of inflammation is to neutralise and repair. Neutralise the bacteria or virus or the antigens that are stimulating the response, and the inflammatory response is mediated largely by these innate systems. And if everything goes very smoothly, there are no symptoms. But of course, you're getting this hand grenade going, and some of those cytokines will actually tell the brain to change the temperature, and you get a fever. It will go to the muscles and tell the muscles to break down unnecessary proteins so amino acids can be fed into more essential amino acids to keep the immune system going. And you get white cells will increase and become recruited to the site of infection, and that will bring its own set of symptoms. And so you get aches and pains in the muscles because the muscles are breaking down. You get a fever, you feel unwell, you don't feel like eating, all those classic symptoms. And they can be quite common to a great range of virus or bacterial infections. Of course, each infection might have its peculiarities by virtue of its own tropism for a particular part of the body. It might go to the lungs, it might go to the kidney. It has its own special characteristics if there is a toxicity for a particular area, like the spike proteins, which seem to create havoc in certain organs.
This is interesting. So when I am not feeling well, I say, I don't feel well, I've got a virus, or I don't feel well, I've got an infection. It's actually not really the infection so much that's making me sick as my body's response to the infection, which is generating these clinical features.
Yes, you'll certainly get sick because of the virus as well, because the virus might have some toxicity. And it also will localise in certain areas, causing damage, and the damage itself, for example, if it's in small blood vessels in the skin, you suddenly notice you've got a rash. In the lungs, you might get a bit of bronchitis or pleurisy, pain. So you do get a modification of symptoms with different infections, and that allows us to make a good guess at the clinical diagnosis. But overall, underpinning all of that are these non-specific symptoms and signs of inflammation.
So these aren't an accident, really. These are the body getting ready to, or the body responding to this infection. So the fever, the breakdown of the muscles, the increase in the white blood cells, the increase in metabolism that goes with that, the faster heart rate, the faster respiratory rate, the increase in the blood glucose levels. These are all the body
exactly
getting into fighting mode, really, aren't they?
Exactly. It's. Remember, we're talking here about systemic infections, and it's crucial for the survival of the host, you and me, to control that very quickly. And to do that, it comes a cost. And the cost is very often the symptoms of systemic inflammation, fever, and because the hand grenade's going off, you can't control it in the same way. The control mechanisms you have for adaptive immunity, and if it gets out of hand, that becomes the problem. And of course, with cytokine storm, which can be a terminal event in a number of conditions, including COVID, in cytokine storm, you have a situation where the inflammatory host response is what's going to kill you.
Yes. Indeed. So infections can kill you, but also the response, if it's overblown, can kill you as well, which is
if it's out of control.
Is what we've seen in COVID, yeah. So very often when someone has an infection, we kind of feel generally unwell, and then often it's localised to part of the body sort of the day after that or a couple of days after that, and you kind of know where it is. So, I remember feeling fairly unwell, and then day after that I developed pain when I was having a wee. So I think, that's a urinary infection.
That's correct, because you've got bacteria there in the bladder or the kidney. And that will cause the systemic symptoms of fever, feeling unwell, muscle aches and pains perhaps. But because it's localised and you've got intense inflammation in the bladder fighting the particular bacteria, or in the kidney, you're going to get kidney symptoms or bladder symptoms, which are caused by the intense local inflammation or the toxicity of that particular bacteria that's infecting.
And of course, this is what we do clinically, isn't it, Rob? If someone comes in and we've got a query sepsis, we think there's an infection, we'll take the bloods and analyse the bloods for what bacteria are in the bloods first, what we call blood culture studies. And then, only then will we give the antibiotics. So we want to take the bloods as quickly as possible, work out what's going before the antibiotics have started doing anything, and then we can specify the treatment after that, because initially someone is just presenting as being septic and unwell.
Yeah, well, very often you have a pretty good idea, generally the type of bacteria that might be causing infection by virtue of where it is, the time, pace, and of course people become sick very quickly with septicemia, which is the name given when bacteria are dividing in the bloodstream, and you don't have time to wait 24 to 48 hours to get your culture back. So you best guess with a particular antibiotics that you know from experience are likely to be most effective. Monitoring the patient very carefully, because they don't get better very quickly. You've got to change the antibiotic, and you wait. You ring up the laboratory and say, well, wait a second, what have you found? Have you found a bacteria and the sensitivities to which antibiotics?
Absolutely. We want the antibiotics to go in 30 seconds after the blood's been taken, and then we can start the treatment.
Absolutely, or just before.
Or 10 seconds, preferably, yeah. I mean, you hear figures like this in severe sepsis. The possibility of dying goes up by about 1% every 10 minutes if the antibiotics are delayed.
Oh, I think that's pretty right. That's right. The mortality from septicemia, is, even in relatively healthy people, can be 20-30%. So if you're unwell and you're old and whatever, mortality becomes highly significant.
So this first video, Robert's a bit of a teaser, really. So we've just sort of floated the things we want to be talking about. As we say, it's probably going to be a series. What we want to do next is to start exploring the historical development of the way that our understanding of immunity has developed, because immunity is so complicated. We've discussed this. We think the best way to actually get an understanding of the immune system as we understand it now is to look at the way our understanding has developed over time. So unfortunately, that's going to have to be the next video, because this is a bit of a demo. So We will be putting more up. They're completely free to view. They're available for everyone. But for now, Robert, thank you so much, all the way from Sydney, Australia, and I'm John Campbell in Carlisle. Thank you, and we'll see you again with Robert really soon.
Thank you very much, John.